Good morning, everybody. It is my pleasure to welcome you to our annual Werner Sampson Visiting Professor Lectureship. Just a brief word about Dr. Sampson. First of all, Werner, our deep appreciation for you supporting this activity. For those of you who've not had the pleasure to work with or meet Werner, he is perhaps the most storied cardiologist in the state of Washington, beginning his practice in the 1950s, doing the first coronary angiogram in the state of Washington, serving as the Dean of Admissions for our School of Medicine for a long time, and of course being just one of the kindest and loveliest people to work with, a mentor to many of us. So Werner, to you, your wife, your family, thank you so much for supporting this activity, our deep appreciation. And with that, I will just very briefly introduce our speaker today. I am delighted and honored to introduce Dr. Valentin Fuster, who's visiting us digitally from New York City today. Dr. Fuster is president of the Mount Sinai Heart Program and physician-in-chief at the Mount Sinai Hospital. He is founding general director of the National Center for Cardiovascular Investigation in Madrid, which is the equivalent of NHLBI in Spain. His storied career began at the University of Barcelona, but he has been professor at the Mayo Clinic and Mount Sinai, as well as being appointed the Mallinckrodt Professor of Medicine at Harvard and serving as the chief of cardiology at MGH before returning in the mid-1990s to Mount Sinai, where he has led their program, as well as serving in prominent leadership roles globally. He's been president of the American Heart Association and the World Heart Federation. He's a member of the National Academy of Medicine. For a long time now, he has been the editor-in-chief of the Journal of the American College of Cardiology. I've been privileged to work with him. He's been a wonderful mentor and friend related to his groundbreaking work in global cardiovascular health. And so without any further ado, it is my real pleasure to introduce Dr. Valentin Fuster this morning. Valentin, thanks for being here and take it away.
Well, thank you very much. It's certainly a pleasure to be with you. And I'm glad when you mentioned Dr. Sampson with the qualities that he had professional and otherwise. And certainly it's a privilege to be the Sampson visiting professor today at the University of Washington in Seattle. I'm sorry I'm not there. It's not perfect, the world of today, but anyway, I will be very pleased to be throughout the day in different sessions and different interactions. And certainly this is the first one, which is basically to talk about an aspect that turned me into it about 10 years ago. For a long time, I was working in the understanding of atherothrombotic disease, from platelets to imaging technology to address the vessel wall, and to very significant aspects until about 10 years ago, when I became convinced that we knew more about disease than about health. And I decided to turn completely around into what is really health. What are the mechanisms that actually support health? And maybe we might find better answers to address disease or to prevent disease. So this is why the title of my presentation today to you is Innovation in Cardiovascular Health. And I say it's an age-dependent situation, because it's quite different to talk about health in a youngster and mid-age or in the elderly. And what is most important, aside of these three different ages that I will be approaching today, is the issue of technology. It's very important to address that if we are going to really try to evaluate what is health and mechanisms that lead to health, better we use the most sophisticated technology available. This is why the discussion is entitled specifically Imagenomics, which is the combination of imaging and genomics throughout the lifespan. And as with the second presentation that I will have later, this is going to lead to two clinical trials that I hope you find of interest. So here's the story. Greg and me as editor of JACC, and Greg as working certainly on the issues of health, and particularly the metrics of Institute of Metrics and Health, and NHLBI decided about 3 years ago to begin to look at the world map in terms of cardiovascular disease. And in the bottom of the slide, you have something that we don't like to talk about it, but is the reality today. And that is cardiovascular disease is increasing, and so cardiovascular mortality. This has an impact particularly in middle and low income countries, but even in high income countries, now we are reaching a plateau. So this whole concept that cardiovascular disease is decreasing, and the statins, the smokings, the interventions, and all of that has been significantly important in the last few years. Something is happening that is counteracting this decrease in cardiovascular disease and mortality that we have been talking for the last few years. And this leads to the next slide, which actually is also from the same group, including Greg, and that the issue is what has happened. And here in green basically is 1990 on the left, 2020 on the right. And to make the long story short, really obesity and leading to diabetes, hypertension, this lipoproteinemia is the problem that we are facing today. Well, it's nice that we say is the problem facing today, when in fact, what we have to do about it. I mean, we cannot stay here and saying, well, let's accept what is going on. So this is why we are so obsessed at the present time to address the issue of health in a way that is presented, at least presented here in a very summarized fashion. About 10 years ago, up until 10 years old, we were working down here with an artery that is, has atherothrombotic disease. And then what we decided to do is to move into the top of the slide and to see how this all begins. But this all begins differently depending on the stage of life that you are. And you will see this today. One is we deal with people from birth to age 20, another from age 20 to 60, and another from age 60 to 100. And this is actually the basis of my presentations today, is to focus in these different ages, what we are learning that can be pertinent for the prevention of cardiovascular disease. And here's on the right are the technologies that we are using today to address this issue of health. First, imaging and genomics, we like to call Imagenomics. Second, artificial intelligence. Third, innovative therapies, and let me tell you what we are talking about. Are the defense mechanisms today actually being a very important trigger for therapeutics? A number of therapies that we are beginning to use today is enhancing defense mechanisms that have been discovered that they are protecting our health. For example, the mRNA vaccines. You know, I am very close friends to those who developed these, and it's interesting, the mRNAs years ago were considered a manifestation of something wrong in the body, of physiological mechanisms, a manifestation, when today we know that a lot of this field, significant amount of this field, is a defense mechanism. And this is how the mRNA vaccines evolve. Look, heart failure. In heart failure, you say, well, let's see the agents we are using. Well, SGLT2 inhibitors is an example of enhancing defense mechanisms. And then we have the issue of the new approaches of combining drugs, you know, for heart failure, whether ACE inhibitors or the receptor blockers and so others. And then you realize that we are moving into a field that is how can we enhance defense mechanisms? And this is a significant future, and I have a lot to say today. And finally, single cell mutations, you know, and genomics. This is very interesting. The monocyte carries a lot of information about us in terms of genetics. Basically, what I'm trying to say is that we are now addressing 3 different ages with very modern technology, with the question is, what is health? And the first one I'm going to address today is actually age 20 to 60. And you may say, why? Because I think one of the challenges at this age is to know whether we are developing the disease or not. How to address this? Well, about 10 years ago, we began to work on imaging technology. I was very involved with MRI, but we moved into 3D ultrasound. And this technology was to address the large arteries, the 2 carotid arteries, the 2 iliofemoral arteries, and then the aorta, in trying to address with 3D ultrasound subclinical disease. And that's how we started. And then we added something very indirect, but at least has some interesting information, which is calcification of the coronary arteries, the so-called coronary artery score, indirectly addressing the presence or absence of coronary artery disease. So we are dealing with 6 sections. And for example, on the left, this is a cross-section with a very early lesion developing. This is longitudinal. And this is 4 years later, how the disease is more advanced. Well, the 3 studies I'm going to be presenting to you today have just been published, and this is going to lead to a clinical trial. And let me address the studies. The first one is what this type of imaging is providing us with information when the disease starts. Well, here is the story of the first study of 4,000 people in Madrid working in a bank, the Bank of Santander, between ages 40 and 55, where we use the technology that I am mentioning. This was published, at least part of it. These are males on the left, and you see that 2/3 of them in color have 1, 2 or 3 or 4, 5 or 6 of the regions with disease that is not clinically apparent and is subclinical. 2/3 in men, already under the age of 50. I will tell you later on that the disease begins at age 20. We have the information for that. But this is the study that we began with. And here on the right, women, half of them already have disease about age 50 or less than 50. Here in the bottom of the slide, what you have, there is a high incidence of early development of disease. This is what I'm talking about. What I didn't mention is that these people are being followed for 20 years, and we are imaging them every 4 years. And on the first imaging, we already found that the disease was progressed in 33% of them. Remember, we are dealing in people between age 40 and age 55. And something that we have not published, but is going to be published very soon, I hope, is that this progression of disease is absolutely dependent from conventional risk factors that are affecting these people at this particular age. The most important, I can tell you right now, hypertension and hyperlipidemia. Well, having said this, now we have the first piece of information. We have technology telling us that disease starts at a young age. Now comes number 2, the Cardia study. Here is age 20 to 40. We were able to get hold of the study with Joy Jones and others, and these are people that between age 20 and 40 were seen a number of years ago, actually about 30, 40 years ago. And at that time, risk factors were tabulated, but no more than that. What we did is we collected the area, and here on the top you have from age 20 to 40, this is the abscissa, and in the ordinate is the LDL cholesterol, how it fluctuates. This is the overall population. Well, then what we do, we computerize this area and we can quantify it. And then we did this with high density lipoproteins, triglycerides. We did this with blood pressure, etc. Well, The data is fascinating. We presented this in 220 about the impact of LDL cholesterol at young age, 20 to 40, who had in terms of events many years later. But actually, this paper that is coming out in the next 5 weeks and was just accepted 2 weeks ago is the following. And this is fascinating. It's fascinating because what we see here, let's focus on the upper part of the slide. This is LDL cholesterol as it was measured at that time is at time 0, which is between 20 and 40 years of age, and what it meant in terms of cardiovascular events later on in life. And these are the events. In red is when the area between 20 and 40 of the impact of LDL cholesterol was high. And here in the bottom is when it was low. This is LDL. We found the same with triglycerides, the same with blood pressure. And now I can tell you, and I have data to convince you, that this age 20 to 40 is absolutely critical in terms of the risk factor profile on the risk of events later on in life, including degenerative brain disease, which I have to talk about it. So this is the data that is going to be presenting very soon. It's new data, is not available, at least I don't know of any study, and that is how you calibrate the risk factors at early age into events later on in life. So we already have 2 pieces of information. One, subclinical disease begins at a young age, and I presented to you the data between age 45 and age 55. And then the second issue is not only is that, but even risk factors at this early age, 20 to 40, even earlier, may tell you cardiovascular events that happen later in life. Second point. And now comes the third point. And the third point is very interesting. If you go to the guidelines, guidelines begin at age 40. And age 40, you apply Framingham, you apply any kind of formula that you wish, and it's all based on events that take place later on. The guidelines completely ignore what goes on between age 0 and age 40. There's no guideline there. And now it's beginning to evolve, but there's nothing really tangible. So what we did is in the 4,000 people of the PESA study that I mentioned you before, between age 40 and age 55, what we did is to look at subclinical disease. And here's the story. Today, if you look at guidelines, an LDL cholesterol in people who never develop a cardiovascular event is considered normal if it is between 80 and 110. This is considered normal. Well, this is not normal if you see subclinical disease. In terms of when all of this was tabulated, we found that you need to have an LDL cholesterol less than 70, at least to be sure that from the LDL cholesterol point of view, you do as well as you can to decrease subclinical disease. Well, this was for LDL. Then in 2021, we published similar data on hemoglobin A1C. Hemoglobin A1C in the concept of prediabetes is interesting. When we look at levels of 5.5 or 5.7 to 6.5, we say this is prediabetes. And then we say it's certainly an alarm system. Well, it's not an alarm system, it's a big problem. Subclinical disease is already there, and we publish very similar data that we have here with LDL cholesterol. So to talk about prediabetes and thinking, well, I didn't get diabetes yet, so it's not a problem, it's a huge problem. And this is what I'm presenting, what we presented in 2021. The same with triglycerides. You say, well, a triglyceride level 150, 175 is no problem. Is a problem. In fact, you need to have triglyceride levels certainly less than 120 or even less than that. So what I'm really presenting to you is that, unfortunately, these guidelines are based on cardiovascular events over age of 40, and what has been considered normal in our society is completely abnormal. If you believe, and I will show you this in a moment, that subclinical disease leads to events later on. In the cardiac study was no subclinical disease, was the risk factors leading to events later on. I will show you data in a moment how this progression of disease leads to events in people who are less young. Well, we pulled these three pieces of data together. And that is first, this is a disease that starts at a young age. The second, this is a disease that the risk factors between age 20 to 40, are worrisome. And third, what is the level of risk factors you are talking about? And then you end up that what were considered normal are abnormal, and an LDL cholesterol of less than 70 is abnormal. And this is leading to the trial that we are now developing, the so-called Precut study. The Precut study of preventive coronary artery disease trial goes as follows. These are inclusion criteria. People between age 20 and age 39 years with no history of cardiovascular disease. And these people are actually going to have an LDL cholesterol level that if it is more than 70 milligrams DL, they will enter into the study. This is abnormal. And here the individuals will be randomized to standard of care on the left and active treatment on the right, which is to bring the LDL cholesterol less than 70 milligrams DL and a systolic blood pressure of less than 120 and a hemoglobin A1C of less than 5.7. What are the endpoints? Progression of disease, as I will show to you. Why? Because these are young people. And therefore, to expect that the secondary endpoint of cardiovascular events take place is not going to be easy because these people are very young. Well, let me proceed into the study. Now focus your attention on the left of the slide. And what you have is people with LDL less than 70 milligrams DL is what we try to reach. How? Red yeast rice, statins and ezetimibe, and if not, glycerin subcutaneously injected, within a period of few months. So this is the approach that we are going to take to drop the LDL cholesterol less than 70. You have to understand that there are a number of young people between age 20 to 40 who have familial hypercholesterolemia, and therefore it's not going to be easy to just drop the LDL with just the statins. So this is the basis of the study. I don't go into other details, but just to comment to you that in terms of the follow-up is going to be 5 years, and this is just for reasons of funding. Now we plan to follow these people for 20 years anyway. But this is just the beginning of a study, which to me is actually unique. And I'm not going to go into the details of what is going to be assessed year after year in these individuals. But I just wanted to point out that the most important background of the studies that we began to do in terms of health is that imaging technologies gave us the sense, first, that this is a disease that starts at a young age, so clinical disease. Second, risk factors, even at ages between 20 and 40, can have an impact later in life. And actually, and this leads to the final comment, that what we consider normal today is actually not normal. All this together leads to the Precut trial. But now, about some of you may be skeptical that the primary endpoint being progression of the disease that we found in 4 years happened in 33% of people, you may be skeptical that progression of disease anatomically with imaging has anything to do with events. I presented risk factors with the cardiac has to do with events, but I didn't present to you data that progression leads to events. And this is something is going to be published very soon, and is the second study that we did, and this is in elderly people, called elderly, between age 60 and 100. We use the same imaging technology that I presented to you with the PESA study between age 40 and 55, the same. So, and here's the story. Now you have cardiovascular events because are older people. And here you say with the first study of these individuals, we have actually a burden of disease that we quantify how much disease is there by imaging. And then we project these into cardiovascular events about over 12 years later. And look at this, the burden of disease were very, very much related actually to the amount of the cardiovascular events years later. So now we go to the Precut study that are younger people. When we see a burden of disease at somebody at age 40, which is burden of disease X, we will transfer that burden of disease as a secondary endpoint into this graph and to say what this burden of disease meant when we had the data in older people, and trying to begin to project the secondary endpoint with projecting events that will not happen at that time at young people, but at least we can predict or project the data that I'm just presenting now. Now, this technology of 3D ultrasound will be automatized in a year. And that is what we are going to be able to do is in the two carotid arteries, the iliofemoral arteries, and the aorta to quantify in cubic millimeters of disease. That is, subclinical disease will be quantified in cubic millimeters. Today, we don't have this automatization yet, but we are now very, very close. What we are using is the device. We are moving the device up and down, and then we can do that. There's something I didn't mention and was in the first slide, and I missed mentioning, but I think it's important. The disease begins in the iliofemoral region. And that is what we found is in over 2/3 of people. This is the region where you begin to see the disease, the subclinical disease, that is not manifested clinically because the arteries are large. And this is why the disease may be manifested for the same time in the coronary system or in the brain because the arteries are smaller. I'm saying this to you because now we are involved, and you'll see this later, in developing countries in which we use the device just to get in the iliofemoral region. That's enough, because that's where the disease begins. And this is, economically speaking, really very little. And there is more. In these countries, what you do, you face the possibility of blood drawing and check cholesterol and diabetes. It's easy to talk, but much more difficult to execute. So in these countries, we use a risk factor profile that doesn't entail blood drawing. Entails the imaging of the iliofemoral region, and then 2 mechanical problems, obesity and high blood pressure, 3 behavioral, smoking or no smoking, poor diet, and lack of exercise. That's what we have. We can now add the other one, which is sleeping. We have not done it yet, but at least what I'm saying to you is that this imaging technology is going to be very, very important. And to us, the most important risk is to see the disease directly. Risk factors is all a statistical aspect. 50% of the smokers may develop an infarct, 50% not. But my friends, if you see a high burden of disease or you see subclinical disease, this is a very important risk factors. Well, anyway, I stop here, but I don't want to stop what happened in middle age, but I cannot get away from genetics. And this is absolutely, in my view, is fascinating. We got into the bone marrow, and let me tell you how. In near 900 people of the 4,000 that we did the 3D ultrasound, we did positron emission tomography with the concept that when we see plaques in the large arteries that are yellow, you will see this in a moment, is a fight between the monocyte of the bone marrow that tries to get into the cholesterol of the artery and tries to get it out. This is what we found. And this was published very recently, actually, and that is the bone marrow PET scanning can show activity. This is in blue here. And this is what we see in the artery. Well, we already published this very recently, but I want to spend some time in this slide, which I think is absolutely critical to understand the disease that we are talking about today. And this is the following. This is without autopsy where the fatty streaks, which now we see with positron emission tomography in the large arteries. And this is actually an interaction of cholesterol and monocytes. And these monocytes actually, we know, come from the bone marrow because we have seen this with the PET imaging. And everything it looks good. And here on the left, in the same individuals, we did magnetic resonance imaging. And that is to look at the arteries in the process of healing. This is fibrotic or calcification. Well, the story is as follows, and this is what we are beginning to see, and it's very, very fascinating. And that is, if you have a low risk factor profile with low cholesterol deposition in the arteries, what is happening is monocytes from the bone marrow that is activated come here and they take care of the LDL cholesterol. They absorb the LDL cholesterol and the plaque becomes fibrotic, as you will see in a moment. And this is what we call compensated disease. Everything has been taken care by the defense mechanism from the bone marrow. But what happens when the disease progresses and there's a high content of cholesterol? What we believe happens, and we are beginning to get data on this, is that the bone marrow cells commit suicide. They are not able to take care of this, and the process continues. And this is called apoptosis. And what we feel this is critical in the acute coronary syndromes, because what happens is these monocytes from the bone marrow liberating metalloproteinases may contribute to plaque rupture when there is a significant vulnerability with a high lipid content. These monocytes that are committing suicide, they also release tissue factor, which may eventually lead to the blood clot. So what we are dealing here is with a very interesting new concept that is evolving, and that is, this is a disease that is compensated or not, depending on how the bone marrow is actually acting. And the bone marrow is okay, except when there is too much deposition of cholesterol as a substrate, probably the apoptotic phenomena takes place and the acute coronary syndromes evolve. But what about CHIP? What is CHIP? And here's where we get into the genetics. Chronal hematopoiesis of indeterminate potential. We have been very involved with these. You know why? Because we measure all of these in the study that I just mentioned to you of 6,000 people between age 60 and 100. Well, anyway, what happens here is in the adult population, let's say over age of 70, about 20% of people, they have mutations of the cells of the bone marrow that are supposed to defend our arteries, and they don't. And actually, two genes that we have identified, one is TET2, and the other I will show you in a moment. Let me explain to you what is TET2. First of all, today the macrophages or monocytes are divided in 6 different types, but I have to go to the simplistic previous classification. Monocytes type 2, they get into a plaque when there is a foreign body, in this case is cholesterol, and they take care of, and the whole thing gets compensated by a fibrotic process and even some deposition of calcium. The problem is when there is a lot of cholesterol in the artery and the plaque is very vulnerable, there's a lot of substrate, and even there is blood clot, interleukin-1 identifies this and goes into the bone marrow, and the bone marrow sends monocytes type 1 that what they do, they clean the artery, completely lies. And this can be very, very problematic. Problematic in what? That you can decompensate a plaque that is already very vulnerable to make it worse. And this is probably where the CANTOS study was successful, with the use of the monoclonal antibody actually blocking interleukin-1, and at least preventing that this process of defense from the monocyte was actually too aggressive. Let me just go. I'm sorry for that. It's a little bit of a problem indeed. Let me just see. Yeah, here it is. Okay, so this is one aspect. And we have the animal model, which is published below, in which the murine model, in which, in fact, by blocking TET2, what happens is the defense mechanism is there, but the motor engine is not working. And this is probably an important risk factor to the elderly population, when in fact TET2 tries to prevent the problem of monocytes 1 that may lyse the artery. And this is what we do with monoclonal antibody blocking interleukin-1. So TET2 should be intact. And now comes the other one that we have found is TP53. And TP53 has a similar situation, but by a different mechanism. And this is actually in the animal model. What TP53 does is it prevents the proliferation of the smooth muscle cells in the atherogenic process to be too aggressive. So when TP53 is actually knocked out in the animal model, in the right, the disease actually develops with significant proliferation. What I'm really trying to present to you here is that imaging has provided a lot of information, but genetics now are coming out with a risk factor that actually appears to be very important. And that is that when we talk about patient with coronary artery disease has high risk factors and genetics, certainly Lp(a), all of this is important. But the genetics of the monocyte as defense mechanism appears to be equally important. And this may explain people that in the elderly age without significant risk factors, they have events. It's because of CHIP. It's because the monocytes cannot get rid of the cholesterol deposited because they don't have the motor engine to do it. And that is the mutations of the genetics. Well, this being said, this was all what I presented about age 20 to 60. And that is imaging and genetics are really making us to understand much better the defense mechanisms that we have. And this may approximate us to address disease much earlier, as with the Precut study. And now, in the next 10 minutes, I'm going to present to you a second challenge, and that is age 60 to 100. Age 60 to 100, to me, the main challenge is actually cognitive dysfunction. And I will show you in a moment that this is the reality in the society that we have today. Cognitive dysfunction and Alzheimer's disease. We are now in a different age altogether. We are not looking whether it's disease or not. We are looking at cognitive function. Here we have Alzheimer's on the left. Alzheimer, about 120 years ago, this was a pathologist, said, my disease is a disease of the arteries. Amazing if you go back to what he wrote. He never explained what disease of the artery was, but certainly it's amazing that the research over the last 100 years has been completely focused on the neuron. I think it's fair. Maybe a neuronal disease with deposition of a number of ingredients that we all know who they are, beta amyloid and so forth. But the problem is, what about the arterial system that is providing nutrition to these cells? And Alzheimer's was very much involved with that. Well, at that time, there was no imaging technology that we have today. And we have the technology here in number 2, which I'm going to be presenting to you. And then, importantly, in 2019, Idekola from Cornell here in New York began to pay attention to the fact that the risk factors that affect the large arteries that I presented to you today already in part 1, they can also affect the arteries of the brain, leading to cognitive dysfunction, dementia, and perhaps accelerating Alzheimer's. This is all the data that he presented in 2019. Well, we are working with collaborators of Idekola right now, and we are very involved in actually cognitive function, dementia, and Alzheimer's. And I'm now going to be presenting to you the data. We started in 2020 with the so-called TANSNP study. The TANSNP study involved actually about 200 individuals in which we wanted to start correlating the risk factors of the large arteries by the methods that I mentioned to you of imaging with cognitive function in Alzheimer's disease. Well, it's very interesting, and this is the hypothesis that was developed. First, risk factors may affect the large arteries of the body, but these same risk factors, this is large vessel disease, may affect the microvascular of the brain. The autopsy data on risk factors in the brain is very much focused on the microvasculature, thinking that hypertension that is not treated, hyperlipidemia or high cholesterol or diabetes may affect a smooth muscle cell proliferation of the arteriolar system decreasing flow. There is not much data on the atherosclerotic process inside the brain, but this is the hypothesis number 1. And this number 2, if there is decreased flow by the mechanisms that I mentioned, risk factors are affecting the vasculature of the brain, is the uptake of glucose in the brain when you use positron emission tomography impaired? And if it is impaired, is cognitive function being affected? And if this happens, can this in a way make Alzheimer's disease to progress? Let me address you these 4 issues, which is what we did in this first study. In the first study, we have 96 individuals, 59 were women, where we measured by MRI the cerebral blood flow. These individuals had hypertension and dyslipidemia, and some were diabetics, high risk factor profile. And what you see in yellow is the decrease in blood flow to the brain. This was very striking to us, actually, with this new technology. But then what we did is PET scanning, see if this decrease in flow means decrease of uptake of glucose in the brain. And here's the data. We published this just a year ago. Here you have the Framingham study towards the right in the abscissa, means more risk factors. And here on the ordinate is the uptake of glucose in the brain. And as you can see, the uptake of glucose decreases as the risk factor profile increases. And here in the middle is hypertension treated and untreated. And in yellow is actually the decrease of uptake of glucose. This is how with color we can actually tell exactly what's happening with positron emission tomography here. So we have risk factors affecting the large arteries. We have a decreased flow. We have decrease of uptake of glucose. And what is interesting here is that the decrease in uptake of glucose now, we have over 370 people that we have worked on. And this is now submitted for publication, and this is fascinating. Higher is the risk factor profile, lower is the uptake of glucose in the brain, in yellow. If the risk factor profile is high, but is not so high, the situation is less. And there is something else going on that I will tell you in a moment. We can measure injury of the brain by biomarkers, like we use troponins for the myocardial actually injury. But that's the data that is very important. So we have risk factors, and then we have decreased flow to the brain, decreasing glucose, and then here what we have is MoCA, and that is dysfunction of or cognitive dysfunction as we measure in a number of these people with decrease in blood flow and decrease in positron emission tomography uptake of glucose. Well, this is all very interesting, but the interesting aspect also is what happens, for example, with Alzheimer's disease. Well, this is very interesting. We are following now or involved with 2,000 families of people with Alzheimer's disease in Spain. And here what you have is Framingham, the risk factor profile towards the right. And here what you have is the uptake in the ordinate of amyloid, actually in the same regions that we see Alzheimer's. So here we are beginning to see a relationship in Alzheimer's disease, or in Alzheimer's disease, they didn't have Alzheimer's, these people, but at least pointing out that risk factors may lead to accumulation of amyloid in a region of the brain that is predisposed to Alzheimer's disease. I think this is very important, but you have to be very cautious, because now we have information that you can have accumulation of amyloid in the brain and not to develop Alzheimer's. So this is a very cautious issue, but certainly the data is quite interesting when you correlate this with with risk factors. Let me see. I'm sorry, because I'm not doing too well here. Let me just see. Well, what we have here is, excuse me for that. Let me see if I can go. For some reason, I don't know why this is not moving. Yeah, well, anyway, let me go into this. This is a second aspect of Alzheimer's disease that we are very, very interested on. And that is, we have an animal model of Alzheimer's. Here we are not doing all this positron emission tomography and looking at the amyloid that gets into the brain and so forth. and the deposition. Here we have something else, and that is this animal model develops Alzheimer's. And what we found is small blood clots that, as you see here, this is beta amyloid, and beta amyloid is thrombogenic. And interestingly, when we gave dabigatran to these animals, actually we found that, in fact, the Alzheimer's disease could be stopped, this progression, and even some regression. And this points out in a paper that is coming out this week, actually, in the British Journal of Pharmacology. They ask us to develop a study of anticoagulation in people who are predisposed to Alzheimer's, knowing that we don't know what Alzheimer's saw in the arteries, whether were blood clots, or what they saw is how the disease is affecting the microvasculature, the risk factors, a completely different mechanism. But this is something that we are thinking now at this time about the trial. But the most important issue is in the previous slide, which is the problem of what I presented to you with the 4 phases. Not the same individuals had the same technology. So what we presented is 4 stages in which they fit very well with the hypothesis that was presented in 2019 by Idecola. This led us to develop the real trial, which is a prospective trial called HeartBrain that we started last year in 1,000 participants, as you see here, at about average age of 55 years. And now here we use all the imaging technologies. And we plan to follow these people, in a matter of fact, for 20 years. But this is actually the ideal study, is a prospective study of how risk factors may actually lead to vascular disease of the brain, not only large vessels, and then the uptake of glucose with PET may be affected, cognitive dysfunction, and this may not be the cause of Alzheimer's directly, but may predispose to the progression. Here in the bottom, what you have are the new biomarkers that we have developed with the group in Amsterdam, which is like troponins in the heart. Basically, any minor injury of the brain can actually be identified, for example, by NFL, which is this release from the axon of the neuron. And this is fascinating, and we have already very interesting data that I cannot present here because it still has to be tabulated properly. But in all of these studies now that we are doing, at the same time that we do blood flow of the brain, positron emission tomography for the uptake of glucose, and at the same time we look at cognitive function, we are addressing these biomarkers that perhaps will be critical to the early or very early stages of the disease. And this leads to the slide, which is the slide that I presented to you, the first slide, and that is we are learning a lot through imaging and also through genomics throughout the lifespan. I only concentrated in 2 types, in 2 ages. I concentrated age 20 to 60 with all the imaging that I mentioned to you before, how the disease starts early in life, and in fact, the importance of risk factors between age 20 to 40, the fact that what we consider normal is abnormal, and led to the Precut trial. And now I presented to you the second age, 60 to 100, pointing out that the risk factors that we don't pay attention that may affect the brain can be tremendously a burden to the brain. And therefore, to start risk factor profile and even imaging technology to identify early problems, I think is critical for the future. And I will tell you something very interesting I learned over the last couple of years by working on the brain. And that these patients come to us, doctor, I don't want to stop smoking and wait, you are making my life miserable and I want to die suddenly. Well, I will tell you the following. When you tell these people, what about the brain? Do you know that these risk factors may affect function of the brain, cognitive function, and even perhaps, we don't know, but it appears that Alzheimer's can progress. They completely change. So actually what I am learning, and I think you will agree today, is that society seems like getting tired of talking of heart disease. And now the brain is a critical issue. quality of life, I guess. And I think the people that I see, they are more interested about the brain. So basically, I presented the two main trials that are now evolving based on everything I presented to you, actually in two different ages. And what I am going to do in grand rounds today in medicine is certainly going a little bit more into the long age, but here is secondary prevention with the poly pill. And here is what we do between age 0 and age 20. This is the most important part of my presentations today, is all the data that we are accumulating in young people, certainly much younger. And this is going to be the presentation that I will have later on in grand rounds. Well, anyway, I finish here. Thank you very much for your attention. And certainly this is open to questions or comments.
Thank you very much, Valentin. That was a remarkable and broad view of where we are today. Yeah, everyone should know how Zoom works by now. And so we have things open up for questions. And I'm going to prefer to put people on audio. So prepare yourselves if you ask a question, because that is for sure the best way to do this. I see a question from Dr. Dicek. I'm going to allow you to unmute. David, if you want to go ahead and try that and ask your question. Yeah,
that was a really interesting talk. It prompts for me the question: are there? It seemed, first of all, I'll give you my impression that the major risk factors seem to come through in predicting cardiovascular disease progression and incidence. Do you think there are major undiscovered risk factors for atherosclerotic cardiovascular disease? And I emphasize major.
Yeah, you know, look, I mentioned to you, obviously they are. You know, there are some others, I'm sure, but you know, the bottom line of the data that is evolving in our studies thus far, we cannot get away from the 8 risk factors that are the conventional ones. You're sure, then you add Lp(a) and so forth, and you may add the sleeping there, and you may add some others. But the fact of the matter is, my friend, what we are seeing now in terms of progression of disease in the right arteries and in the brain is based on the risk factors that we talk conventionally. So I think we should discover more risk factors. Look, CHIP, we didn't have any idea about CHIP 5 years ago. And this is a risk factor. It is a genetic one coming from a defense mechanism that probably is not operational. So there's no question that we are moving forward. But I think, frankly, my message today is that, God, we have to get earlier and earlier in life. We are missing the whole opportunity. And every time, as editor of JACC, I have papers coming out with all these great guidelines over age of 40. I think to myself, you know, maybe we are in the dark ages still. I'm sorry to tell you that, but the reality is new technology has not been even appreciated into the aspects that we are now seeing.
You can also type questions into the chat and raise your hand, and we'll grab those questions. But I have a question. I don't think I can let you mention your trial with glycerin in the protocol for aggressive LDL lowering without asking for you to help us step back and take a broad view of this new technology. You know, the largest, I think, uncontrolled experiment maybe in modern times is currently running in the UK, where glycerin is going to be broadly adopted or is already in wide use. So what is the impact of glycerin going to be, and how should we think about using it, and where will it be 20 years from now?
I don't know if it's going to be glycerin, but one of the main problems today is adherence to medications, frankly. And you know this well. This is why we have a poly pill. And the fact of the matter is, if you can give a subcutaneous injection twice a year, you are probably on business. It's how you are, you know, renewing your bank account. Whatever it is just something simple that you can do, and so forth. Inclisiran can be used, and we are going through all the mechanisms of safetiness and so forth. And certainly in these young people, we are going to find a number of them with high LDL cholesterol. We will not be able to drop to the levels we want with ezetimibe and statins. So, Greg, I think the future is going to be as simple as we can. And in a way, it's a little bit frustrating. And you know, the fact that cardiovascular disease has decreased somewhat in the near past is the use of statins, but it seems we have to take a drug to take care of our risk factors rather than changing behavior. And this is why I still think we have to go to children and getting into an educational tool. Inclisiran, in a drug close to it, I'm sure they are coming in the future. It's going to be much more simple, but it's unfortunate that we have to deal not with our own nature, but rather with you know, with all these drugs and so forth. It's frustrating, but this is what happens. This is who we are.
We have a question typed into the chat, so I'll just read it. Until data is available to support pharmacological therapy in young people, what do you recommend for treatment ages 20 to 40? I find young people very hesitant to start statin or even blood pressure meds.
It's a good question. First of all, why we are involved with the Precut study? We are all conscious statins for 70 years. You're going to put somebody. We are all concerned about this. But the fact is, we found that of everything I presented today, maybe I will be more clear later, the most important risk factor we have seen is the risk factors at young age in terms of events in the future. So when we start giving statins in people age 40 and 50, and we say it's okay, I am just saying to you, sure, we have to be careful. We don't know what this means in the long term. But you know, what we see as a result of not taking care of the risk factors is very, very significant. Now, you know, I would put my daughter with an LDL cholesterol of 150 at age, let's say 35. She's a little bit older, but anyway, at age 35, I would put her on statins. I would do as much as we can with diet, and I may use maybe ezetimibe. I think is more less of a problem, theoretically. I would do the best I could, but you know, if you come with an LDL of 200, as I had today, one of my patients, actually age 35, we have to start moving very aggressively. We cannot accept familial hypercholesterolemia with LDLs more than 200 and to say, you know, I'm afraid of a statin. So it's all common sense and being cautious. Your question is important.
I'm going to take advantage of getting to ask one more question, and it's about dementia, which I thought was fascinating, the trial that you described, you're working in that area. And it's actually about the distinction that we make between what we've called vascular dementia and Alzheimer's. And I'm wondering if that's a false dichotomy. What you suggested is really maybe we shouldn't be distinguishing between them, even though traditionally in the field we do.
You know, I feel very awkward to make statements coming from the cardiac field, but I can tell you I am convinced that there is a mix here. And you know, and it has been dichotomized for many years, and this comes from the research arena rather. Clinically speaking, look, we are now dealing with a huge number of people with family histories of Alzheimer's and degenerative brain disease, and I can tell you, I just feel that you cannot be so easily divided. And I think the vasculature is the call.
And we have a question typed in from Dr. Kirkpatrick, which is, given the heart-brain issues of older individuals that you outlined, do you think there will be more of an emphasis on geriatric cardiology in the future? Is that a field that will grow? Is that an area where we'll train people? Well,
I'd like to say to you that it's never late, frankly. And we have good data on hypertension and brain disease. And that is, you can treat hypertension, not to treat hypertension for years. And at age 65, you begin to treat it. The data beginning to evolve is positive. So let me put it in this way. About geriatrics, let me tell you, whether we like it or not, this has to be absolutely emphasized in the future. like children. In fact, I will tell you, to me, the future, and I think I have an article coming out, are the two streams of life. We have already spent a lot of time at the very age, between 40 and 60 and so forth. I think we have to really move on into very early in trying to prevent disease and very late in trying to do the best we can. Quality of life is the problem up there.
I think that is a great point to end this presentation on. Thank you again for being our Sampson visiting professor, and thanks everyone for joining and the great discussion and questions. We're excited to have you spend time with our fellows and trainees today. And everyone have a good day. Thanks again for this great presentation.
It's a pleasure. I will tell you that Seattle means a lot to me. And I tell you a short story if you give me 1 minute.
Yeah, please.
Very basically, I had great mentors, and they said to me, one mentor, you should go out as medical student out of this country every year during the summer. I ended up in Liverpool working with Professor Sheehan, a great pathologist. My background is pathology. And he showed a slide one day, and I couldn't see anything in the slide. Then in the microscope, couldn't see anything. Now you need electron microscopy, but you always have to start from the very simple. Electron microscopy shows a platelet clot. And I asked in 1961, what a platelet clot means in this patient. He says, died of a heart attack. And I said, what that means? And he said, I don't know if it is the cause or the consequence, but you're going to do the thesis on platelets. And actually, it was amazing. And then I ended up in Edinburgh doing my PhD thesis on platelets and coronary artery disease and so forth. And the reason why I'm mentioning this to you is the platelet told me that the problem was in the vessel wall. This led me to completely work in MRI, and I spent time just MRI at autopsy, looking at the vessel wall. And then I realized that the whole thing was behavior. And then I realized that everything had to do with don't understand health. So I just wanted to give you a sense of how one moves, in life and so forth. But this is certainly my trajectory. Whether it's for good or for bad, that's a different reason, but that's what happened.
Thanks so much, Dr. Fuster. We'll end it there. I think you have a little break and then you'll join our fellows in a little bit. But again, thanks very much. And
it's a pleasure.
Dr.
It's a pleasure.
Sampson.
I'll see you soon. Thank you.
Take care, everybody.
Thank you.